Good evening, everyone. Happy Monday to you. You are watching Medical Mondays right here on News Channel 5 Plus. And tonight we are so happy to have Dr. Reddy here with us with the Pain Management Group. Doctor, we've learned a lot tonight.
Great.
I think you've answered some great questions for folks and given that free medical advice. Does it get better than that? It's absolutely free. So
Absolutely.
we really appreciate your time this evening. And as we kind of come to an end here at the show, we have a few more, a little more time left with you. But we talked a lot about the back. We talked a lot about the back. So we're going to kind of move to other parts of the body that also, of course, we have chronic pain issues with.
Absolutely. So after the spine, probably the most common thing that we see is knee pain. So what can we do with knee pain? Again, it starts with imaging and things like physical therapy, but some of the interventional techniques become a little bit different in that we're not doing epidural steroid injections, but we do steroid injections in the knee joint itself. That's something that we just do in office, so it's fairly simple. And then there's something called viscosupplementation, so that's kind of putting a gel cushion into the joint again. And then lastly, if those two techniques don't help, and you've seen a surgeon or you're not a candidate for surgery at this time, then there's something very similar to what we do in the back with the radiofrequency ablation, but it's a different set of nerves. So the nerves that innervate the joint capsule itself, we can also go in and do an ablation on. So it's called a genicular nerve ablation. So a lot of options for the knee as well.
Yeah, it's great to hear. We have talked a lot about options tonight that are non-surgical. That's really, it seems to be the last resort. That's
absolutely. So I think most surgeons these days, especially for the spine, would say that surgery itself is, kind of the last option when there's no other treatments that are helping or beneficial. And a lot of surgeons even these days would say that something like a spinal cord stimulator comes even before back surgery rather than after back surgery, because you don't get to try a back surgery before you have it, whereas you do get to try a spinal cord stimulator. So unless you have alarming symptoms like weakness and again bowel and bladder incontinence or loss of control, then a lot of times you can avoid surgery with some of the less invasive techniques.
And I feel like a lot of folks, they do experience that pain. Their first reaction is, oh, I'm gonna have to set an appointment. I just know I need surgery. Is that a misconception? And what are some other misconceptions as a doctor that you'd love to, as we have you here tonight, just kind of clear the air?
So yeah, one of the major misconceptions is that you will go and just kind of have surgery, or that if you're getting sent to pain management, that the only thing you're getting sent for is to just get pain medications. But it's really for assessment of your pain and to see what all the options are. It kind of depends how you get into our clinic. A lot of times if you've already seen the surgeon, they'll send you back to us to say you're not quite ready for surgery, let's try some of these less invasive techniques. But a lot of times we get patients straight from primary care doctors once they've had a little bit of imaging to show that they have some degeneration in the spine. So we really get to work them up from square one and make sure that they don't have any alarming symptoms, and then try all the kind of stepwise treatment. And for most patients, you really do get to avoid having back surgery, but we have a few that eventually then we would refer you to a surgeon. So we kind of fit between a primary care doctor and seeing a surgeon and trying some of those less invasive techniques. So you don't always have to have surgery. You don't always have to have injections in your spine, which is another misconception. If conservative treatment like physical therapy and a few simple medications treat pain, that's great. We're happy to do that too.
You're in that nice happy medium place where we like to live. So
absolutely.
There are a lot of options that are non-invasive and non-surgical. And kind of speaking of that delicate care, there's also another group of folks I'd like to address tonight, and that's pregnancy. Dealing with pregnant a woman comes in and you're kind of dealing with different options. How do you go about treating someone?
So one of the major things that you really have to be careful with during pregnancy is that you want to be careful with the types of medications that you're using. So almost all medications that are used for pain management typically have some kind of risk to mother and baby during pregnancy. So that's a really important discussion that we like to have with patients, is discussing what the medication options are. You also have to be a little bit more creative when it comes to imaging, and going with imaging that you've had before pregnancy, because you can't expose the mom to radiation. So that's another kind of complicating factor. So generally when it comes to pregnancy and any kind of back pain, you try to be as conservative as possible, and really you don't want to do even most of the procedures we're going to do expose you to some form of radiation. So we don't do any of that kind of stuff during pregnancy. So physical therapy is tolerated, and then finding things kind of that are non-invasive at all to try to relieve your pain. Things like massages, those are always nice.
It does, it does pose a challenge. That's definitely for sure. You know, when you are pregnant, how do you know whether it's just your common pregnancy back pain or when it's time to actually seek help?
So I would say that if you're having symptoms to the point where you can't sleep, or it's really kind of an acute change in your pain, meaning that you've had pain, and then all of a sudden you have a very different type of pain. If you have symptoms that are now going down a leg, like numbness, tingling, weakness, where your leg's giving out, if you have any change in bowel or bladder patterns, and again, that kind of stuff can also change during pregnancy because there's a lot of different body parts that are affected by having a baby within you. So really the things that are concerning are big changes in the type of pain that you're having, and pain to the point that you're completely non-functional. You're not able to do any of the things that you need to do during the day, or any of those neurological changes that we discussed.
That's really great advice. I think that's very interesting for folks to know, because you always want to keep an eye on the situation, but you don't want to make a call if it's not necessary, but you also don't want to put yourself or your baby at any sort of risk.
Absolutely.
Another topic too along those lines of kind of knowing when is the right time to call in. Folks that they pick a certain occupation that poses more of a challenge, a more physical occupation where you are doing physical labor. And how do you approach someone with the advice of a doctor? How do they have to get the job done, but they also need to take care of themselves. So how do you handle that dilemma?
So there's a lot of different occupational hazards. So beyond just kind of hard labor and things like that, when it comes to hard labor, you want to be really safe at work and not overdo it or strain your back too much. If you can't do it, sometimes it's not something that's for you. So you don't want to overdo it and cause problems like an acute disc bulge that's going to compress your nerves that you may have to have treatment for. So taking it easy, resting at night, using heat, ice, things like that, using anti-inflammatories. If that kind of stuff treats your pain, you're probably not overdoing it. But if all of that does nothing to your pain, you may be overdoing it. One of the other kind of overlooked things is positioning. A lot of us work at desks all day. So positioning when you work at a computer and you're typing is really important for your neck. So making sure that you're working at eye level and you're not looking up or down all day, and that we all set up a little bit straighter.
I'm working on my posture here while you're talking about that.
Yeah, I mean, so that's something that's commonly overlooked. But if you think about it, 25 years of looking up and down is going to cause some wear and tear on your neck. So that's something that you really want to be mindful of.
Kind of coming full circle here, we discussed this at the very beginning of tonight's show, and that was talking about really something very special that you all offer at the Pain Management Group, and that is therapy and kind of mentally getting healthy. Because I will say, when you are displaced from something like back pain, for instance, you can't work, you were a construction worker, a firefighter, and it puts you out, it's not only physically painful, it can be mentally disturbing as well to deal with something like that, especially for a long period of time. Kind of go back into reiterate why you all offer that and why it's so very important.
Absolutely. So when I think about it, I see a lot of patients every day, and fundamentally changing what you can do every single day and limiting yourself because of your pain is bound to cause anxiety and depression. I mean, it's rare that we have a patient that has had years and years of pain that isn't affected by depression and anxiety somewhat. So we really felt like it was important to address that component of it, and not just say we're going to focus on the pain and treat the pain. But I think if you don't talk about the depression and anxiety that goes along with having chronic pain, you're really never going to be successful at truly treating the pain and the whole experience of a patient's day. So that is something that's really important to us. And again, some of it is also biological, in that when patients have a traumatic experience that causes pain, some of that imprints in the same area of the brain that pain also lives in. So, you know, there's a biological component to why people have depression and anxiety with their pain, but there's also the kind of day-to-day component of it, which is unavoidable. And we just want to acknowledge that and make sure that we're taking care of that component as well.
Taking care of all aspects of your health. And real quick, if we have a second here left, we do have one more caller I want to get to before we get to running out of time. Good evening. Can you hear us?
Yes.
Hi there. Real quick, what can we help you with this evening?
I just had a question for the doctor, hoping he can help me. I have been having some pain down my leg, and it seems to have occurred 6 months after I had an ACL reconstruction. Any thoughts on that?
All right, about 30 seconds.
So it depends, but one of the things you want to consider if you've had an ACL construction is how you were positioned during the surgery. So was one of your nerves entrapped or compressed? And also, was there a direct injury during the surgery? So, you know, nerves go in a certain pattern, but they're not always predictable. So you want to make sure that you're not having any pain from a nerve injury, either from the surgery itself or from positioning for the surgery, which are, you know, positioning injuries are not as uncommon as you'd think.
All right, appreciate you squeezing that in there. We wanted to get that last call in. We'll be right back after this quick break.